Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi, my name is Morgan Hayslip. I am a PGY2 emergency medicine pharmacy resident at MercyOne Des Moines Medical Center in Des Moines, Iowa. And today I will be talking to you about getting patients bup running in ED-initiated buprenorphine, specifically looking at the emergency department initiated buprenorphine for opioid use disorder article. Some learning objectives for today include reviewing treatment of opioid use disorder with buprenorphine to compare and contrast the efficacy of extended-release buprenorphine with sublingual buprenorphine, and to apply the principles of buprenorphine initiation in the emergency department to a patient case. For some background, about 5.7 million individuals in the U.S. have an opioid use disorder. Opioid overdose deaths are the leading cause of death in people less than 45 years of age, resulting in each overdose death being about 38 years of potential life loss due to the young nature of this population. For my site specifically, we have about 4,700 emergency department visits with a chief complaint of withdrawal or overdose in the past 6 months. So this is a rather large proportion of our emergency department population. 7-day extended release buprenorphine may expand the reach of initiating medications for opioid use disorder in high risk and hard to reach individuals who visit the emergency department and can be administered in low levels of withdrawal. So this study aimed to determine the most effective option for initiation of opioid use disorder treatment from the emergency department. More background on buprenorphine itself. Its mechanism exerts its analgesic effect via high-affinity binding to the mu-opioid receptors in the CNS. It displays a partial mu agonism and a weak kappa antagonist activity. Its analgesic effect plateaus at higher doses, and buprenorphine can then behave as an antagonist, which allows for relief of withdrawal symptoms and cravings without causing euphoria. The extended release formulation is injected subcutaneously and becomes a liquid crystalline gel depot that gradually releases buprenorphine. Buprenorphine is really well tolerated. Its adverse effects include headache, anxiety, constipation, perspiration, possibly some fluid retention in lower extremities, and sleep disturbance. So overall, relatively well tolerated. Extended release buprenorphine was approved by the FDA on May 23rd of 2023, so it is a newer medication that has come out. Looking at our 2020 ASAM practice guidelines for the treatment of opioid use disorder, the goals of treatment include to suppress opioid withdrawal, to block effects of illicit opioids, to reduce opioid cravings and stop and reduce the use of illicit opioids, to promote and facilitate patient engagement in recovery-oriented activities such as psychosocial intervention. For specific recommendations on initiation, they say that the location can be within the clinician's office or home-based. For indication, we want to target patients experiencing mild to moderate withdrawal, so that is typically a COWS of 11 to 12 or a COWS greater than 13 if primarily using fentanyl. COWS recommendation is not based on any trials and is per clinician recommendation. Timeline-wise, we typically want to initiate 6 to 12 hours after the last use of short-acting opioids, so this would include something like heroin, and 24 to 72 hours after last use of long-acting opioids, so this would be something like methadone. For initial dosing, they recommend 2 to 4 milligrams initially and increasing in increments of 2 to 8 milligrams as needed. The guidelines did state that further research is needed to compare the effectiveness of different buprenorphine formulations, and that was not something addressed in these guidelines specifically. Of note, also, the X-waiver requirement was removed in December of 2022, allowing more prescribers to be able to prescribe buprenorphine and expanding its reach. As for some more background, I have a flow sheet for buprenorphine initiation. This is what my site specifically uses, although it is applicable to other sites. So typically we would start with buprenorphine 8 milligrams sublingually, and we would repeat the COWS score in 1 hour and then dose buprenorphine according to the COWS score. We would repeat that COWS scoring every 1 hour until symptoms are controlled or a max daily dose of 32 milligrams has been reached. Looking at some other similar trials, our first one is by D'Onofrio and colleagues in 2015. It was a randomized controlled trial of 329 patients in an urban teaching hospital emergency department. They looked at referral versus brief intervention versus sublingual buprenorphine naloxone and found with sublingual buprenorphine naloxone, there was increased engagement in treatment, decreased illicit opioid use, and decreased use of inpatient addiction treatment. Button and colleagues in 2022 conducted a retrospective cohort study of 72 patients, specifically looking at opioid use disorder with inpatient buprenorphine initiation. So slightly different than our population that we're talking about today. But they looked at low-dose sublingual buprenorphine naloxone. So they provided patients with a low-dose patch and then up-titrated with sublingual buprenorphine naloxone. They found that low-dose initiation is very well tolerated and versatile. And then Sazer and colleagues in 2025 conducted a retrospective cohort study of 69 patients, specifically looking at extended-release buprenorphine administered in the emergency department. They did not have a comparator group to look at, but they did find that there were increased retention rates compared to previous studies of sublingual buprenorphine. Getting into our trial for today, again, it is the emergency department initiated buprenorphine for opioid use disorder trial, otherwise known as ED Innovation. For study design and methods, this was a parallel two-group open-label individually randomized trial with a patient population across 29 geographically diverse emergency departments in academic and community sites across the United States, conducted from July of 2020 to August of 2024. Inclusion criteria included moderate to severe opioid use disorder as defined by DSM-5, urine drug screen positive for opioids, and a COWS score of greater than 8. Of note, this protocol requirement was changed on April 5th of 2021 as a result of a parallel ancillary non-randomized study that demonstrated feasibility and safety of directly initiating 7-day extended-release buprenorphine with COWS of 4 to 7 without a lead-in dose of sublingual. So after this change, it became a COWS score of greater than 4. Exclusion criteria included a urine drug screen positive for methadone, pregnancy, receiving medications for opioid use disorder within 14 days, required ongoing opioid medications for pain, requiring hospitalization, or non-English speaking patients. The intervention in this study was the extended release buprenorphine injection of 24 milligrams, which equates to about 16 milligrams per day. The control group was sublingual buprenorphine of 16 milligrams per day until follow-up. For patients with an initial COWS score of 4 to 7, instructions for unabsorbed buprenorphine initiation were given. This self-initiation allowed for up to 12 milligrams within the first 24 hours. For patients with an initial COWS score of greater than or equal to 8 milligrams sublingual buprenorphine was administered in the ED, and then they were provided with sublingual buprenorphine for outpatient. Of note, either group could receive additional doses of sublingual buprenorphine as needed during the ED encounter for withdrawal symptoms. They could also receive antiemetics, alpha agonists, and NSAIDs as needed. Study endpoints include the primary endpoint of engagement in formal opioid use disorder treatment at 7 days, which was verified with the treatment source. Secondary outcomes included engagement in treatments at 30 days, self-reported non-fatal overdose events at 30 days, craving scores at 7 days, self-reported past 7-day illicit opioid use at both 7 and 30 days, treatment satisfaction at 7 days, engagement in treatment with medications for opioid use disorder at 7 and 30 days, self-reported emergency department visits and hospitalizations, and the treatment effectiveness assessment, which was essentially an assessment to gather how well the patients were doing with their treatment. It included questions like, how much better are you with your drug use? Has your health improved? How much better are you at taking care of your personal responsibilities? Are you a better member of the community? There were also 2 safety endpoints, which included precipitated withdrawal and hospitalizations and death. For statistical analysis, 1,700 patients were needed to detect a difference of 18%, which the study did meet. Analysis was conducted according to the intent to treat principle. Treatment engagement at 7 days was analyzed using weighted generalized estimating equations. Craving and treatment satisfaction scores was analyzed with the analysis of covariance, and number of days of illicit opioid use was analyzed with generalized linear and mixed model with a negative binomial distribution. As for some baseline characteristics, these study groups were very well matched. I do want to point out that patients with unstable housing in the past 12 months was a larger proportion than our typical patient population in the emergency department, with about 50% of patients reporting unstable housing. Also, about 75% of patients reported use of public insurance. While well matched between groups is not typical of our typical emergency department population. Looking at more baseline characteristics, again, wanting to point out relatively similar between groups. However, the days since last reported opioid use was 0 in both groups, so patients were initiating the same day as their last use, and the median COWS score at enrollment was 9 and 10 between the groups. Also wanting to point out that fentanyl was positive in the urine drug screen of about 75% of patients in both groups, and 77% of patients had opioids plus another substance in their urine drug screen. Also of note, 10% of patients received a dose of buprenorphine before randomization. So while about 40% of patients are positive for buprenorphine on their urine drug screen, 10% of those did receive a dose before randomization. Looking at some results, treatment engagement at 7 days was a 45% in the extended release buprenorphine group and 42% in the sublingual buprenorphine group, so not statistically significant. And there was not much of a difference when COWS score was stratified as 4 to 7 versus greater than 8. Looking at our secondary outcomes, specifically pointing out the number of ED visits and hospitalizations, which was much lower in the extended release buprenorphine group compared to the sublingual group. While there wasn't any statistical significance associated with this, this could have a big impact on our emergency departments, especially as we deal with a boarding crisis. I also want to point out the treatment satisfaction scores and the treatment effectiveness assessment score, which were both higher in the extended release buprenorphine group compared to the sublingual buprenorphine group. Looking at our safety results, hospitalizations and death were relatively similar between the groups, and most of the time the adverse event was not related to the study medication. There was a less than 1% incidence of precipitated withdrawal, which is something we tend to worry about with treating opioid use disorder. However, this shows that it is very safe to initiate opioid use disorder treatment within the emergency department. The author concluded that both extended release and sublingual buprenorphine can be safely and successfully initiated in the emergency department, that more patients were engaged in treatment at 30 days than at 7 days, likely due to an ongoing lack of timely open access follow-up care for opioid use disorder treatment after emergency department initiation. About a third of patients were enrolled below the currently established clinical threshold for buprenorphine initiation, showing potential for expansion of ED-initiated buprenorphine. They stated that craving scores and numbers of days with illicit opioid use were lower with extended-release buprenorphine, which is likely due to its advantage of sustained concentrations over time. They stated that repeat ED visits were substantially less frequent with extended-release buprenorphine, which again could be an important advantage for many health systems that may justify the added cost of having the extended-release buprenorphine. They also concluded that patients in the extended-release buprenorphine group were more satisfied with their overall treatment experience and responded more positively on the treatment effectiveness assessment, to which they stated that a positive experience with buprenorphine is important, as it may motivate subsequent treatment initiation attempts. Looking at some strengths and limitations of this study, strengths include its prospective randomized design, patient-centered outcomes, meeting power for the primary outcome, and outcomes confirmed via source when possible. So they didn't solely rely on patient survey if possible. Limitations include limited external validity. Sites were required to establish relationships with clinics, which is not the typical for emergency departments. They also excluded non-English speaking patients, which again removes a large chunk of our patients and limits the external validity. There also was a limited observation period, meaning adverse events could have been missed. The study was also not powered to detect a difference in COWS score of 4 to 7 due to this protocol change partway through the study. They also did not test ED-initiated 30-day extended release buprenorphine. They only tested the 7-day extended release. Potential biases include partnership with community clinicians and opioid treatment programs that may have made follow-up more accessible compared to a typical emergency department. Some data limited by self-report or use of patient survey. Randomization was stratified by site and insurance status, so this could have inadvertently created some bias. And additional doses of buprenorphine and ancillary medications could have been given as needed for withdrawal symptoms during the ED encounter. About 10% of patients in both groups received additional buprenorphine, with the extended release group receiving an additional 4 milligrams and the sublingual buprenorphine group receiving a median of about 7 milligrams. Looking at clinical versus statistical significance, neither the extended release or sublingual buprenorphine was statistically significantly superior in engagement in opioid use disorder treatment at 7 days, which shows that either option is appropriate and safe for ED initiation. Looking at our previous studies, again, that study from Caesar and colleagues in 2025 was the only one to look at extended release buprenorphine administered within the emergency department. They did not compare directly to sublingual buprenorphine, but they did find increased retention rates compared to previous studies of sublingual buprenorphine. While that was not found in this study, I do wonder if perhaps those ongoing relationships with the clinics led to some bias related there. For some further discussion, emergency departments must have ongoing relationships with community clinicians and opioid treatment programs to set patients up for success with treatment. Increased ED initiation of buprenorphine will increase access to treatment for patients with opioid use disorder, especially with the removal of the X waiver required for prescribing buprenorphine. This really provides an opportunity for ED providers to initiate treatment. Areas of further research include ED initiation of 30-day extended release buprenorphine and ED initiation of buprenorphine in COWS scores of 4 to 7, as the study was not powered to fully assess this outcome. Overall, I think either extended release or sublingual buprenorphine are good options for ED initiation of treatment for opioid use disorder. In summary, ED-initiated buprenorphine is an important access point for treatment for those with opioid use disorder. Both extended release and sublingual buprenorphine are safe and effective options for opioid use disorder treatment, and relationships with opioid treatment programs are key to encouraging continuation of treatment once our patients leave the emergency department. Thank you so much for listening, and if you have any questions, please feel free to reach out.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.